management strategy.
Thank you. Thank you, everybody. And after Rohit Sharma and Virat Kohli, it's like Vijay Shankar coming out and trying to do something. And I'm speaking on behalf of Dr. Jayashankar, and I thank Dr. Haigreve Rao and the entire team to have us here so that we can discuss this extremely important topic. The topic is essentially from Dr. Jayashankar's slides, and I would acknowledge his contribution to the making of this talk. So, what we are dealing with is hypertrophic cardiomyopathy, prevalence and the characteristics. We know it's an autosomal dominant condition. Women are diagnosed less often and later. Disease prevalence is actually much lesser than, or rather, much higher than what is absolutely seen here, 1 in 500. Triggers for evaluation is usually very incidental or any significant symptoms later on in life because of the diastolic dysfunction. And the differential diagnosis includes the other non-HCM causes of LV hypertrophy, including the young and athlete's heart kind of a situation, or in the elderly, an infiltrative situation like amyloidosis. Histologically, it has myocardial disarray, fibrosis, small vessel disease. 25% of them have resting LVOT obstruction, and SCD is mainly caused by ventricular arrhythmias, which may be or may not be amenable to ICD therapy. Identification of such patients at high risk is the cornerstone of management of sudden cardiac arrest in these patients, and now we have a significant experience in understanding a number of phenotypic characteristics that can be used to identify these patients who may be candidates for a primary prevention ICD. In 2024, the diagnostic criteria are very fixed. As you can see, the MRI as well as the 2D echocardiogram that can be useful for the same. But the adverse events that you can see are progressive functional limitation along with atrial fibrillation, heart failure, thromboembolism, and last but not the least, which requires a prognostic or a predictive capacity on the part of the electrophysiologist, the cardiologist, or even the physician who's treating the patient, the prognostication for sudden cardiac arrest. In pathophysiology, the understanding for why this might happen might actually be because of the dynamic LVOT obstruction, mitral regurgitation, the energetic dysfunction, and the diastolic dysfunction leading to myocardial ischemia, which in turn may contribute to atrial and ventricular arrhythmias, thereby leading to an enhanced cardiomyopathy. The underlying mechanisms, as we said, it may affect young and frequently asymptomatic patients. The annualized rate is less than 1% and mediated mainly by ventricular fibrillation. Compare that to elderly patients where fibrosis has already set in, or there is a cardiomyopathy that sets in, resulting in reentrant arrhythmias where the mechanism of the arrest might actually be different. Majority occur when in sinus rhythm and are precipitated by PVCs, especially when PVCs are seen in younger patients and patients at the peak of their exercise and during high periods of stress. They are precipitated by runs of ventricular tachycardia, rapid atrial fibrillation, or accelerated idioventricular conduction. Asystole and pulseless electrical activity have also been associated with sudden cardiac arrest in this group of patients. As we discussed, the potential mechanisms include either the fibrosis by itself or something that is contributing to electrical inhomogeneity in the substrate, mainly atrial fibrillation with the rapidly changing RR intervals or primary onset of reentrant ventricular arrhythmias. The risk factors in favor of sudden cardiac arrest in patients with hypertrophic cardiomyopathy are non-sustained ventricular tachycardia, more commonly seen with increasing hypertrophy, suggestive of increased fibrosis and disarray. All studies demonstrated a significant association with NSVT and sudden cardiac arrest when NSVT has been defined as 3 consecutive beats at a rate of greater than 120, lasting less than 30 seconds. Age less than 30 years was associated with a 4-fold increase in the risk of sudden cardiac arrest, but there's no increased effect in older patients. So much so that above the age of 60, you really have to think twice whether you want to give these patients an ICD. Severe left ventricular hypertrophy with a mean wall thickness of greater than 30 mm has been universally used to signify severe hypertrophy, and these patients get an ICD directly. Systolic blood pressure response to exercise, a very challenging test, less often performed, defined as a failure of the systolic blood pressure to rise by greater than 20 millimeters of mercury during exercise, or by a fall of greater than 20 millimeters of mercury from the peak reported or recorded systolic blood pressure. Above the age of 40, we do not know the prognostic significance of this response. Familial history and genetic markers have an average hazard ratio, irrespective of the definition, of about 1.27, with troponin T mutations associated with a higher risk of sudden cardiac arrest, despite milder hypertrophic conditions. Syncope. Syncope in HCM is a Pandora's box. You have to be able to figure out the history of the patient to be able to figure out an arrhythmic cause of the syncope as compared to a non-arrhythmic cause of the same. It's not uncommon for them to have neurally mediated syncope, both vasovagal, situational, and carotid sinus mediated syncope, and orthostatic hypotension, which in turn leads to the syncope. Patient gets evaluated, diagnosed with hypertrophic cardiomyopathy, may actually get an ICD when it's probably not required. The average hazard ratio with unexplained syncope, however, is very high. It's around 2.68, and as such history remains the cornerstone of the decision making at this point in time. LVOT obstruction with gradients greater than 50 millimeters of mercury are thought to be clinically significant when dealing with the prognostication for sudden cardiac arrest. Increasing atrial fibrillation, left atrial size are as a predictor of sudden cardiac arrest, examined in 5 studies using survival analysis, and mainly is related to the RR intervals variability that may happen in these patients predisposing to ventricular arrhythmias. Only the largest study in terms of age has been known to contribute to sudden cardiac arrest. Younger the age, greater the chance that it might actually happen in the presence of larger risk factors. But when you increase the age of the patient, there is a reduction in the sudden cardiac arrest risk that you can actually have. NYHA functional class, when reported, is not an indicator for prognostication for sudden cardiac arrest. And finally, males have more fibrosis on histological examination and experience more exercise-induced ventricular arrhythmias as compared to females. Invasive electrophysiological studies have no place in risk stratification of these patients, and late gadolinium enhancement is now thought to be an improvement or an increasing prognostic factor. 15% has been given in some cutoffs, but the latest guidelines do not use it as a major criteria for the implantation of an ICD in the absence of NSVT. Systolic function has been advocated by some investigators, and in the latest guidelines, presence of aneurysms have been thought to be an indicator for the implantation of an ICD, as well as a reduction in ejection fraction less than 50%. In clinical guidelines, the 5 major risk factors, therefore, include NSVT, unexplained syncope, abnormal systolic blood pressure response, family history of sudden cardiac arrest, and extreme left ventricular hypertrophy diagnosed as greater than 30 mm thickness of the interventricular septum. It requires the presence of greater than 2 major factors, and ICD implantation is reasonable, especially in patients with familial history or the thickness of the myocardium or recent unexplained syncope. Whereas in all the others, you actually have to have both or at least 2 criteria to actually be able to document this. In suspected hypertrophic cardiomyopathy and a 3-generational family history, we have to rule out other mimics which can actually be causing this kind of a picture, and as such a 12-lead ECG, a genetic evaluation, as well as figuring out what the imaging actually says is important to be able to diagnose these. When we send these patients for genetic analysis, it is not uncommon to find no pathogenic mutation found, which makes screening all the more difficult, and these patients should be reevaluated as and when the databases are updated. Going on from there, so the guidelines for individuals with clinical hypertrophic cardiomyopathy, when you are phenotype positive, after the initial baseline evaluation, is reevaluation every 3 to 5 years with a CMR for risk assessment or to evaluate for suspected morphological changes. The evaluation for suspected morphological changes is still a class 2B indication. And in asymptomatic adults, you want to do every 2 to 3 years. And in children or in symptomatic adults, exercise testing remains the cornerstone of management. You can screen family members with electrocardiography and 2D echocardiography in asymptomatic family members, but I do think that given the relatively poor negative predictive value, it might actually be useful for us to have genetic screening, especially if the index patient has a positive genetic mutation, and use that to screen the family members. It is exome analysis that is done in the index patient, which in turn is then applied to the other people in the family to be able to diagnose the genetic positivity. The genetic positivity need not actually explain the phenotypic presence of the disease, but may warrant a closer follow-up of these patients as compared to those who may not have the disease itself. Risk assessment for sudden cardiac arrest or sudden cardiac death in HCM has to happen at initial evaluation and at every 1 to 2 years. It's a class 1 indication. During this evaluation, it has to be a personalized history, along with the family history of premature sudden cardiac arrest, the LV wall thickness, and the presence or absence of the non-sustained episodes of ventricular tachycardia. A slight confusion or a controversy exists as to the duration of monitoring that is required to document this sudden non-sustained ventricular tachycardia. We do not really understand that very well, and all the studies have been done on a routine 24-hour monitor. Value of longer imaging or longer monitoring of these patients for diagnosing non-sustained VT is currently unknown. At greater than 16 years of age, it is reasonable to obtain an echocardiographic LA diameter and a maximal LVOT gradient to assist in shared decision making with a class 2A indication, as is in a patient less than 16 years of age. Calculate an estimated 5-year sudden cardiac arrest using criteria. So going on from there, let me just skip this slide for the want of time. The pharmacological management definitely involves the use of medications. Nowadays, it seems Norpace is available consistently and it's a useful drug. There has been a recent non-randomized trial talking about the use of pacing, interventional pacing for the purposes of reducing the gradient. But all said and done, we do not have a good way to reduce gradients in these patients. Beta blockers remain a big cornerstone of therapy. There is slightly the role of SGLT2 inhibitors to help symptomatic relief, and mavacamten remains to be seen if valuable in both reducing the obstruction as well as in non-obstructive patients. Unmet need and future directions, therefore, is A, for our country, we need to figure out what are the genetic mutations prevalent and how can we have screening. Number 2, improving management as such and risk stratification of arrhythmias in patients with hypertrophic cardiomyopathy, both the non-sustained VT as well as the atrial fibrillation that associates with it, incorporating new risk factors to improve screening, risk stratification, and disease monitoring, and redefining the criteria